Welcome back. Next, we are going to talk about genetics with Brianna Gross. Brianna Gross is a genetic counselor at Children's Hospital of Philadelphia who specializes in neuromuscular disorders. She is passionate about helping patients and their families understand the role of genetics and genetic diagnosis in their medical care. So, Brianna, I will turn it over to you.
All right. Can everyone see everything okay?
Yep, it looks great. Thank you.
Fantastic. Thank you so much for coming today and listening to my discussion about genetics and why it's important to know about. I will start off by talking a little bit about genetic counseling and some genetics basics. We'll also review inheritance patterns, different genetic testing, and the results that might return from a genetic test. We'll review family planning and some counseling considerations. So what is genetic counseling? Genetic counseling is an advanced training in medical genetics as well as counseling techniques. It is to encourage patients to make informed, non-directed decisions. We are there to help guide by interpreting information and to offer support in decisions that are made. I like to consider myself a translator of the body. I help kind of others understand the hard natural biological processes in a language that makes a bit more sense because not everybody is a science person. We hope for every single patient to cater to what makes them most comfortable in decision making and understanding. So my approach to different patients is different based on who they are as a person, where they come from, how they learn, and so on and so forth. There are a few different types of genetic counseling. There's 4 main categories, being pediatrics, prenatal, cancer, and adult. For me, I work in pediatrics. I work at Children's Hospital of Philadelphia. I'm even more subspecialized because I only focus on neuromuscular disorders. But my job is also a bit complex because I test parents, so that would be adult genetic counseling, and I also test prenatally babies and fetuses. Therefore, I kind of dive into both prenatal and adult as well. We have a big foundation or a big national database for finding a genetic counselor, which I can provide a link to anyone who might be interested. We are the National Society of Genetic Counselors. So I want to take us back to biology, high school biology, genetics 101, to make sure that we're all on the same page. So in our bodies, we have millions and millions of cells, and almost every single cell has a nucleus. A nucleus is like the command center. It kind of dictates what the cell does and when it happens. Inside of this nucleus, we have all of our genetic information. And our genetic information is stored in chromosomes. And these are small structures, very small. You can see them under a microscope though. And we almost always have 46 chromosomes. There's exceptions to every rule. And they're broken up into 23 pairs. And this is because you receive 1 copy of a chromosome from your mother and 1 copy from your father. These structures house our genes. Therefore, we have 1 copy of a gene from our mom and 1 copy of a gene from our dad. And we have about 20,000 genes that are stored in these 46 chromosomes. Our genes are like recipe books, and you'll hear me talk in analogy, and I think for me personally, that's the best way to learn genetics and understand them fully. So the genes are like little recipe books that provide our body with instructions to create a protein. And proteins are what makes us who we are. It helps dictate how our heart beats, when our eyes blink, the way our hair grows, and everything about us is due to proteins. Our genes are written in its own special alphabet language. So unlike our alphabet, which has 26 letters, our genes use DNA language, and there's only 4 letters, A, T, C, and G. So here's a little schematic. This is my mini instruction book. So we could pretend that the book is a chromosome and we are on the DMD chapter. The gene is for the dystrophin protein is DMD, and it would be step-by-step how to create the dystrophin protein. I wanted to also include a picture of chromosomes here just so you can have a little bit more of a visual of what a chromosome actually looks like. So this is a copy of what it would look like under a microscope. As you can see, they come into 23 pairs. They're numbered based on size, number 1 being the biggest pairs and 22 being the smallest. The last set is the sex chromosomes, which determine if you're male or female. For females, we have 2 X chromosomes, and for males, there is 1 X chromosome and 1 Y chromosome. And in this image, it's a male karyotype. Karyotype means just picture of chromosomes. So let's talk about mutations. What are they? A mutation is a change in the spelling of a gene that causes the body to not be able to properly create a protein. Mutations is more of a colloquial term. A more scientific and more descriptive term is to refer to it as a pathogenic variant. I'll talk a bit more about variants later on, but for now we'll just call them mutations. So back to my analogy about it being a recipe. If I were to make a cake and I took out the flour, the baking powder, and the baking soda, ultimately, I would end up with something that's not quite like cake. So similarly, the body tries its very best to read the instructions it's given, and it tries to make a product, but ultimately with the mutation, the end result is just not the same. To be a little bit more scientific, I'm going to break this down. I hope this is not too overwhelming. So the upper left and right green boxes are our hypothetical gene. The first thing the body has to do is read our recipe. So this would be called transcription. The body reads every letter in the alphabet. As you can see, the DNA reads A, A, T, T, C, C, G, G. The next part of making a protein would be translating it. So I like to think of translation like creating cliff notes, an abbreviated version that makes more sense and is more consolidated. So it's easier to read and easier to understand. This would be translation, where it is just the simplified version, cutting out all of the unnecessary things. Then ultimately, the body is able to read the cliff notes or the translated product and create the protein. As you can see on the right-hand side, the gene that has a mutation in it is unable to make a proper protein. And therefore, the body is missing or has a protein that's incorrect. There are different types of mutations, and I wanted to review some of the basic ones. We have deletions, where there are chunks of letters or a single letter missing from a gene. In this instance, this sentence is supposed to read, "The dog ran outside." But when there's a deletion, it says, "The ran outside." As you can see, there's a lot of room for interpretation about what "the" is. What is it that ran outside? The body would similarly be making a protein that's not quite explanatory and not quite we don't understand what the moral of the story is. With duplications, there would be extra letters or letter, and in our example it would be the dog ran outside. Also could be very unclear. Could there be another object that ran outside? Unknown. Substitutions are when there is a letter change. In the example, the dog ran outside, it would be the log ran outside, which again completely changes the end of the story. Here's a little bit more of a scientific way to look at a mutation. So in the above bolded letters, the DNA reads AAT, CGC. And I provided some examples with substitutions, deletions, and duplications of what it would look like. So with a substitution, the C was switched to a G. With the deletion, the T was deleted. And with the duplication, there's an extra T. Now we'll talk a little bit about inheritance patterns. So genes and genetic disorders are inherited in many different ways. The one of the types of ways you can inherit a genetic disorder would be an autosomal dominant inheritance. And I'm just going to preface, I'll review all of this in a little bit more detail after I give you a little summary. So with autosomal dominant inheritance, one mutation within a gene is enough for a person to present with symptoms. In autosomal recessive inheritance, there needs to be 2 genetic mutations, one on each copy of the gene to present with symptoms. And there's X-linked inheritance, where there is a mutation on a gene that's located on the X chromosome. Typically, in that instance, we'll see males being more affected than females. Females may be unaffected or mildly affected, depending on which gene it is. And there will be some instances where you might find in X-linked disorders that a female is the only individual that presents with symptoms. Typically, if that were to be the case, it would be because males are so severely affected that it would be an early miscarriage if there was a male that had that genetic mutation. With autosomal dominant inheritance, a child might inherit their genetic mutation from a parent. An alternative to having an autosomal dominantly inherited genetic disorder would be due to a mutation that occurs spontaneously. In the genetics world, we call this de novo, meaning a new mutation. We all have de novo changes in our genes, and that's kind of what helps evolution. We all change a little bit, slightly different than our parents, but it is something that no one can control where a spontaneous mutation happens, nothing anyone could have done or known about to look for. And sometimes it happens in a gene that can cause a mutation that the body doesn't understand well and can't make the protein properly. In an instance where somebody has an autosomal dominant disorder, there would be a 50% chance of passing that mutation to a child. So if you think about it, you have one copy of the gene that has the mutation and one copy that's functioning properly. And there's a 50-50 shot that you either pass the one that works or the one that doesn't work to a child. In autosomal recessive inheritance, we typically see parents being asymptomatic genetic carriers. That means that they have one working copy of the gene and one non-working copy that has a mutation within it. There are a few different outcomes when 2 carrier parents come together and have children. The first would be the possibility of a child presenting with symptoms and having a genetic disorder, the one that the parents are carriers of. There would be a 25% chance of that happening. There would be a 50% chance of a child who is also a carrier, just like mom or dad. Whether it be mom's copy or dad's copy, that's what adds up to the 50%. And there is a 25% chance that a child would inherit both working copies of the gene. In that instance, the child would not be at risk to develop symptoms and also would not have children in the future be at risk for that genetic disorder either. I'm going to talk about 2 instances with X-linked inheritance, the first one being with an asymptomatic female carrier. An asymptomatic female carrier can pass along a mutated gene on their X chromosome to their sons and their daughters. So overall, there's a 25% chance of a child presenting with symptoms and a 25% chance to have a child who's a carrier. And then there would be a 50% chance of a child not inheriting that mutation. So another way to look at this type of a statistic would be if a female were to have a son, there's a 50% chance that that son inherits the genetic mutation on the X chromosome and therefore would present with symptoms and have a genetic disorder, a diagnosis of one. There would also be a 50% chance if a female were to have a daughter, that that daughter inherits that genetic mutation on the X chromosome. That daughter would be just like mom and be an asymptomatic carrier. For men, if there is a man who has an X-linked disorder, there would be 100% chance that their daughters inherit the X chromosome with the mutation on it. That's because the dad would not have any alternative X chromosome to give their daughter. And all sons of a man who has a X-linked genetic disorder would not be at risk for developing symptoms because they inherit their Y chromosome. I know that maybe people are unaware, and I don't think it's ever really talked about in biology, but the father is actually the individual who determines our sex, because females only have X chromosomes to give their child, but men have the option of either passing their X chromosome or their Y, making us either male or female. And as if genetics weren't complicated enough, unfortunately, I say this all too often, there are some genes that act in both autosomal dominant and autosomal recessive fashions. And I wanted to bring this up not to confuse others, but because there's many genes in our neuromuscular community that exhibit this. So some examples are RYR1, TTN, SYNE2, SCN4A, COL6A1, 2, and 3, and CAV3, and there's many more actually. And the reason why this is, a general rule of thumb, again, there's exceptions to every rule, as with most things in genetics, is because it depends on where in the gene the mutation occurred. So there's some areas that are typically associated with autosomal dominant, and some areas that are typically associated with autosomal recessive. I don't want to go into much more detail because it would be very gene specific, but that I just wanted to bring up. So we recommend genetic testing in a few different instances. We recommend genetic testing when there's a positive family history, where an individual has either a parent or a close relative who has a diagnosis or is at risk for having a diagnosis based on the symptoms that they have. We'll also recommend genetic testing in instances where symptoms are present, whether the symptoms are very clear cut to a genetic diagnosis and we feel as though we know it when we see a patient on exam, or we are suspicious based on many different symptoms that are going on. And also in the instance of a positive screening result. A screening result is something that is non-diagnostic, but shows or proves that there might be something underlying going on. So I'll kind of start with genetic testing from small to big. So with single gene analysis, we are looking for spelling errors in a single gene. We typically do this type of testing today when a patient has very striking symptoms that are associated with a very specific genetic disorder, or in the instance that there's a family history and we know of the genetic mutation that runs in the family. With panel testing, this is a test that encompasses more than one gene, and it is performed to increase the likelihood of identifying a genetic change to explain the symptoms. These genes typically are very similar, and they have overlapping features, but in total are different from one another. The chromosome microarray is a little bit different. It's a test that looks for extra or missing pieces of chromosomes. This does not analyze on the single gene level. I like to think about it as like a New York City skyline. Our buildings are our chromosomes. And with a chromosome microarray, we could see if there's extra or missing floors or entire buildings gone or an addition of an extra building. But we can't see into the rooms on each floor. This test is the bread and butter test and is recommended for any child who experiences multiple anomalies that are not specific to a well-delineated genetic disorder. And what that means is many body systems that are affected, more than one. So whether that be the brain and the mouth, whether that be the brain and the pancreas, whether that be the muscles and the heart, it is recommended for many individuals. It's also recommended for anyone who experiences autism spectrum disorder or any other sort of developmental delay, intellectual, motor, or language. The next test is whole exome sequencing, which is the second clinically available test that is large. It looks at actually all 20,000 genes in our body. But more specifically, it looks at the genes that we are most suspicious about. We don't get all 20,000 genes back with all of their information. It's filtered. So based on the symptoms that somebody experiences, only information about the genes that could potentially explain the symptoms would be given to us. This particular test looks at the parts of genes that provide the instructions to create a protein. It does not look well into the areas of the genes that do not provide direct instructions to create the protein. This is because of the technology that we use. We call the areas of the gene that provide the instructions the exome, hence whole exome sequencing. Whole genome sequencing is a newly clinically available test, and it is very similar to whole exome sequencing. The biggest difference being that it is able to look into not only the exome of our genes, so the areas that provide the instructions, but it also looks into the parts of genes that don't provide the instructions. These areas are called introns. At this point in time, our knowledge on introns in our science community is not where we would like it to be. There is a lot of lack of information about what introns functions are, and we have quite a ways to go with that information. So to talk about the different results that might return from a genetic test, we can get a positive result where we do identify a genetic change that can explain the symptoms that a person experiences. This would be an answer. We can have a negative result where we don't identify a genetic change in the genes that we were looking at. However, with a negative result, we don't always exclude the possibility that there's an underlying genetic reason for a person to present with symptoms. It might be that our science does not quite know what gene that might be yet, and we have to wait for further research and understandings of our genome. Or it might be that we were looking in the wrong area with a smaller test. We can also have the dreaded uncertain result, which adds another layer of complexity to things. This is when we're unsure if we found the answer to explain the symptoms that a person experiences. And we're able to interpret test results as positive, negative, or uncertain by looking at the changes that the lab reports out that they were looking for. So I know I had mentioned mutations and mentioned that they were referred to as pathogenic variants, but I do want to go into more detail about what a variant is because I understand that it can be very confusing and a lot of information to process. So variations of the spellings of our genes is what makes us all different from one another. An example could be a black 1968 Corvette, a red 1968 Corvette, one that was a model from 1971 and a 1983 Corvette. They're all different, even when they're made in the same year. They could be different colors. They could be used and well-loved, or they could be brand new. But they're all made from Chevrolet. They're all Corvettes. We have, in our science world, we are aware and we have a database that has the most common changes in our genes that is seen in the population. So that's what we compare someone's genetic information to when we're doing a genetic test. We look at what does most people have, what's seen very frequently in the population at this area in the gene. How do we spell it? So we classify variants on how the body interprets the difference that particular change makes. So now I'll show you guys my little drawing about the classification. So we have benign variants, meaning it is so prevalent in the population, so many people have this change, it is known to not cause any harmful symptoms to a person. There's also a classification of likely benign, meaning that there's some evidence that's not there, whether that be it's not seen enough in the population for it to be considered benign. But in this instance, the laboratory feels it's very reasonable to say that this does not cause any symptoms in a person, this particular change. These are all, so the benign and likely benign variants are not reported out on genetic testing results. Occasionally, I will call a laboratory and get that information if we're very concerned or suspicious about something, but it is not typically reported out because the laboratory feels so confident that it is nothing, that change. It's just normal human variation. The next classification is a bit more complex, and I'm unsure if there's families on here who've experienced this, a variant of uncertain significance. My next slide will go into more detail about a variant of uncertain significance, but this classification of a variant is used when there's not enough supporting evidence to confirm that a spelling change in a gene is either something that can cause symptoms, and there's also not enough information for the laboratory to say that it does not cause any symptoms. There's also likely pathogenic, which is when there's very compelling information to say that the variant identified can cause symptoms in a person. And there's also pathogenic, aka the mutation. With the variant of uncertain significance, I gave an example here, cat with a C to cat to a K. A laboratory will use the variant of uncertain significance classification when there's just not enough information. In our example, they're very similar. There's a chance that the body understands what the recipe is supposed to look like and potentially could create a product that looks and is functioning very well. But we just don't know. And some reasons why laboratories use this classification is because maybe there's no information. It's never been reported before in the general population. Maybe it's seen in the general population, but we don't have any information if anyone's been reported with symptoms. Maybe the protein prediction models, which are computer systems that kind of act the body and see what maybe the protein product would look like. And also maybe it's in an area where there is no mutational hotspot, meaning that the area of the gene has many mutations that are known to cause symptoms in a person in that small area, or maybe it's not in an area that causes that. So there's a lot of different factors that come in with the variant of uncertain significance to get that classification. So another way to look at it, usually with negative results, it would be a benign variant, likely benign variants that are not reported out, and it would just say there is no genetic changes identified. We can have the positive results, which would be the pathogenic variants and the likely pathogenic variants. And then with variants of uncertain significance, although they're a little confusing, there are often times where when we see a variant of uncertain significance, we can say, this does not look compelling. This isn't a gene that causes symptoms that do not look like our patient's symptoms, and we can say that this is negative and contributing to normal human variation through our clinical interpretation. And there's also instances where we see a variant of uncertain significance and we say, this looks exactly like our patient. The information that we were able to find about this variant is very compelling, and we feel comfortable calling this a positive result. I want to talk a little bit about the reports because I know that they're very dense. So here's our little checklist. Almost all reports will have a type of test listed. In our example, it'll be the comprehensive myopathy panel. It would talk about the gene that they found a change in. So it'll list the gene. In our example, it's ABCC1. It will also give you the location in the gene that the change was identified. I like to think of C as coordinate. So on the 100th letter in the gene, the A that we typically see in people was switched to a T. It would then give you the corresponding amino acid change. An amino acid is just a building block of a protein. A protein is made up of a bunch of little amino acids. So the little part of the protein where we typically see an ARG, which stands for arginine, it was switched to a proline. And now I know that maybe means nothing to you guys, but I just wanted to put it out there. With zygosity will be listed Zygosity refers to how many copies of this change do we see. So a heterozygous change is when only one copy of the gene out of the two that we have has the genetic change of interest. If it said homozygous, it would be that both copies of the gene have the exact same spelling difference. So let's say it was 100 A to T, both copies would have a T on the 100th position in the gene. It would give you the classification of the variant. In our little example, it would be a pathogenic variant. And it then goes on to give you information about the gene. In a fake example, we're going to say that it's associated with a stellar personality. And the report will also give you specific information regarding the variant. So as I was saying, it'll give you population frequencies. It can talk to other individuals who maybe have been reported to have the same change, and so on and so forth. So here's a couple sample results. The first one on the top left is a result that is associated with Charcot-Marie-Tooth syndrome type 1A. In this instance, the gene, as you can see, is PMP22. The variant is a gain, meaning that's a duplication. Zygosity, because it's not quite fitting in the box of heterozygous or homozygous, they tell you that there's 3. Because again, we typically would have 2 PMP22 genes, but in an instance of CMT1A, there would be 3 copies. And the variant classification as pathogenic. For the last result on the page, the interpretation is a positive result, and that's because there's 0 copies of SMN1, meaning that both copies of the SMN1 gene are deleted. This would be a homozygous deletion because there's the same deletion on both copies of the SMN1 gene. For my families who know SMA very well, you would know what SMN2 copy number is, but that at this point in time is not quite relevant to our discussion. The SMN2 gene is another gene, and our testing for SMA will give you that information about another gene. In this case, it'll also give you the inheritance pattern, which is autosomal recessive. Here's a little bit more information about a test report. In this instance, there was a 1 likely pathogenic classification of a variant, and that's because there was a duplication of a chunk of information on the DMD gene. Similarly, the zygosity is 2, referring to the fact that there was 2 copies of this duplication seen. The DMD gene is associated with Duchenne and Becker muscular dystrophy, and the clinical summary details all different symptoms that one might experience with Duchenne or Becker. And if you were to read further, it talks a little bit about the variant. So now I want to review family planning. I'm going to start with carrier testing. Carrier testing looks for autosomal recessive disorders and some X-linked disorders. There are recommendations put in place for all females who are either pregnant or in the process of getting pregnant by the American College of Obstetrics and Gynecology, which is colloquially referred to as ACOG. ACOG makes a recommendation that all pregnant women and women who are going to family plan are recommended to have carrier testing for, at minimum, 4 genetic disorders. The first being spinal muscular atrophy. This was added due to the effects that treatment has on the natural disease course of symptoms. Hemoglobinopathies, which are blood disorders. Cystic fibrosis, which is a lung and pancreatic genetic disorder. And Fragile X syndrome, which is the most common inherited form of autism and intellectual disability. There are options to have more genetic testing for carriers. You can have a universal carrier testing, which looks at many different hundreds of autosomal recessively inherited disorders, and there's no discrimination about which ones are included on based on who you are and where you come from. There's also ethnicity-driven expanded carrier panels, which looks at the most common genetic disorders based on your ancestry and will test you for that too. I want to make note that many of our neuromuscular disorders are not included on carrier screening. So even if you were a family that was aware of carrier screening and had intensive carrier screening results, there's a very good chance that the neuromuscular diseases were not included on it. And that's a big limitation to carrier testing. And that's something that as a family, everyone should look at to make sure that if they have a family history, that that disorder would be included on their carrier screening. It's really important to know your genetic standing for being a carrier, because it allows identification of other individuals that are at risk, not only for your future children or current children, but also for your other family members, your parents, your siblings, your nieces and nephews. So there are different ways to test pregnancies and family plan. If you are identified to be a carrier and your partner is also identified to be a carrier of the same genetic disorder, or if you have a child who was diagnosed with a genetic disorder. The first kind of more tangibly understandably information would be the testing that you receive when you're already pregnant. There's two ways to test a pregnancy, which would be amniocentesis and chorionic villus sampling, which is referred to as CVS, and I'll talk about these a bit more in detail on the next slide. These two are procedures that allow you to test the pregnancy. There's also pre-implantation genetic diagnosis, where you can test an embryo before you're pregnant. There's a few different types of pre-implantation genetic testing, also referred to as PGT. In our instances in the neuromuscular world, this testing would be for monogenic disorders, meaning that it's a single gene that causes a genetic disorder, and that's referred to as PGT-M. There's PGT-A, which looks for any extra or missing chromosomes. And there's also PGT for structural rearrangements. And that's when chromosomes switch pieces. So a little piece of chromosome 1 is switched with a little piece of chromosome 2. That has different implications. And I will not go into detail about them, but if you have questions, please feel free to reach out. With an amniocentesis, which is pictured in the left picture, a needle is placed through the abdomen and through the uterus of a pregnant woman. It is guided with an ultrasound, and that is to make sure that we are getting a sample that is from not where the baby is located in the uterus. What they do is they take a couple tablespoons of amniotic fluid, which the baby does not miss. For me personally, I have never had an amniocentesis procedure, but from other women that I know who have had an amniocentesis, they describe it as a really intense cramp. And that's just because it does go through your muscle wall. The second procedure is a CVS, or chorionic villus sampling, which is when the catheter is placed through either the vagina or goes through the belly, similar to the amniocentesis. And that depends on where the placenta is located, because this is essentially a biopsy of the placenta before the placenta is fully formed. So they'll take a little piece of the chorionic villi, which is pre-placenta. Chorionic villi, what happens is, I'm not sure if you're able to see me, the little projections come together and form a thick, healthy placenta. So they take a little piece of it to biopsy. And this is because the placenta is created from the same cells as the embryo and the fetus. The CVS procedure is typically done between 11 weeks and 13 weeks of gestation, and an amniocentesis would be performed between 15 and 20 weeks of gestation. Of note, I realized I failed to mention with the amniocentesis, how are you testing the baby through the amniotic fluid? This is due to the fact that there's genetic information floating around from kidney cells, from urethra cells, from skin cells, so they're able to get that from the baby. With pre-implantation genetic testing, here's a little picture of what a embryo looks like and how they take a little piece of it to test. So it starts out with in vitro fertilization, or IVF. Regardless of if an individual has infertility issues or not, they need to get the embryos before that they're formed. They have to do it themselves. So that's why they need to go, an individual would need to go through IVF. So after a couple months and a couple rounds, when they stimulate the female ovaries to produce more than one egg at a time, they collect the eggs. And when they feel they have a sufficient amount of eggs, they'll collect a sperm sample and put them together in a petri dish. They then wait for the embryos to start to grow. When there's a big cluster of cells, they take a few cells from the embryo that are to soon be used to create the placenta. And yes, there is a way to tell in an embryo which cells will create the baby and which cells will create the placenta. And they take that and test it for the genetic disorder that is in the family or that two parents are carriers of. Then, after they test all of the embryos that are present, they will give you the information about the genetic standing of those embryos, and you can select which embryos are implanted. So there are some psychosocial considerations I just want to review because I think it is very important. So with genetic counseling, and genetic testing, dealing with families going through genetic diagnosis, there are many complex emotions. Besides anxiety being a huge driver, there's almost this inner conflict of being fearful of the unknown, but also being fearful of the known and what to expect. There's sometimes individuals who might experience extreme sadness, but also extreme joy that they have an answer and that their diagnostic odyssey has stopped. There's a lot of issues and complex emotions that come with disclosing to a newly diagnosed child. As a parent, you're trying to process what might be going on with your child, but there's so many feelings about trying to explain it to your child who's actually the individual experiencing those symptoms. It can be really challenging when we get unexpected diagnoses. Sometimes even in the medical profession, we are surprised by answers we get from genetic testing. And sometimes the families are very surprised by what we receive, which is really hard because you want to balance your expectations and you want to prepare yourself for when results come back. And it's really hard when you prepared for things that you didn't think you would have to ever worry about. There's complex emotions with ambiguous test results that adds a lot longer kind of waiting period and adds time to the diagnostic odyssey that you were really hoping for an answer from or a non-answer. Sometimes it's easier to receive no than it is to receive a maybe. And also it can be hard when we diagnose somebody who is asymptomatic at the time or presents very mildly. I find this often with parents of children who have an autosomal dominant condition and their child expresses the symptoms much more severely than they do. And they went their whole lives not knowing that they actually have a genetic disorder too and they have symptoms, but it just never affected them on their day-to-day life or was not something that was strong enough for them to go seek help for, and they just accepted themselves. So with that, I just want to say thank you so much for your time and listening to me nerd out about genetics. If you have any questions, comments, concerns, please don't hesitate to reach out. I'm always available via email, and my email is down below.
Thank you, Brianna. Thank you. We did get a couple questions that have come through. This person says they have limb girdle R1 However, when my mother was tested, she came back negative. Wouldn't she at least show the same change, even though she is deemed just a carrier?
So with carriers, you typically females or males would not present with any symptoms. If her genetic testing came back negative, it may be that that second copy of the gene um, had a spontaneous error that was not inherited from mom or dad.
Okay. And another limb-girdle question, actually. Is it possible for a mom to have limb-girdle 2 and her child to have a different subtype?
So I wouldn't say never. With genetics, I never say never, but it is very unlikely for that to happen.
Okay. And does insurance pay for genetic testing?
Oftentimes, insurance will pay for genetic testing. I recommend, if you're considering genetic testing, to call your insurance company if approval was given. Usually, a letter of medical necessity is needed to have the testing approved. Alternatively, the laboratories usually have a really great system where you can call and you can determine your out-of-pocket cost,
Okay.
which is very helpful.
Okay. And you might have touched on this, but I'll ask it again. If a child tests negative, would a parent be negative?
Not necessarily,
Okay.
because of the new mutations that can spontaneously occur.
Okay. I do not see any more questions that have come through. So thank you very much for your time this morning.
Thank you
Have
guys.
a great rest of your day.
You
Thanks,
too.
Brianna.
Bye.